Atrial fib, total disorganization of atrial electrical activity resulting in the loss of effective atrial activity resulting in the loss of effective atrial contraction. Atrial rate can be 35060 min. P waves are not visible. They are replaced by fibrillatory waves. Ventricular rate varies, but the rhythm is typically irregular, results in decreased G or T loss of atrial kick and/or a rapid ventricular response. Clots may form in the atria, putting the client at an increased risk of stroke. Treatment: rate control and anticoagulation. Atrial flutter, recurring, regular, sawtooth-shaped flutter waves, rate 200 to 350. MVP: mitral valve prolapse, may have palpitations, dizziness, and lightheadedness. Chest pain can occur, but its etiology is unknown in this client population. Chest pain does not typically respond to anticoagulant treatments such as nitrates. Beta blockers may be prescribed for palpitations and chest pain. Interventions: adopt healthy eating habits and avoid caffeine as it stimulates and may exacerbate the symptoms. Check OTC meds or diet pills for stimulants such as caffeine or ephedrine, as they can exacerbate symptoms. Reduce stress and avoid alcohol use. Begin an exercise program, preferably aerobic exercise, to achieve optimal health. ABES is indicated for clients who have prosthetic valve replacement, repaired valves, or a history of infectious endocarditis, as MVPs may place the client at an increased risk for infective endocarditis. Beta blocker: any of various drugs used in treating hypertension or arrhythmia. Decreases force and rate of heart contractions by blocking beta-adrenergic receptors of the autonomic nervous system. Coronary arteriogram angiogram, invasive diagnostic study of the coronary arteries, heart chambers, and function of the heart. Client should have N4 line started for sedating meds. The femoral or radial artery will be accessed during the procedure. General anesthesia is not given. Instruct the clients: do not eat or drink anything 6 to 12 hours prior to the procedure depending on the particular healthcare provider performing the procedure. Client may feel warm or flushed while the contrast dye is being injected. Homeostasis must be obtained in the artery that was cannulated for the procedure, mostly the femoral artery. Compression is applied to the puncture site and the client may have to lie flat for several hours to ensure homeostasis. If the procedure is just a diagnostic study, the client will often go home the same day. Automatic dysreflexia, hyperreflexia, massive, uncompensated cardiovascular reaction by the SNS in spinal injury at T6 or higher. Due to an injury, the PNs cannot counteract the SNS stimulation below the injury. Classic triggers are distended bladder or rectum DRT, bladder irritation, bowel impaction, second per second, severe HTN up to 300 mm Hg systolic, throbbing headache, diaphoresis above the injury level, bradycardia 32-40 min, piloerection, goosebumps, nausea and flushing. This is an emergency situation requiring immediate intervention to prevent hypertensive stroke and seizures. Management: raise Hob and then treat the cause, catheter the PD if needed, and assess for kinks in existing catheters. Perform digital rectal exam. Remove constrictive clothing to decrease skin stimulation. Contact HCP. Alpha-adrenergic blocker or an arteriolar vasodilator nifedipine may be prescribed. Elevate HOV to 45 degrees or high Fowler's to decrease HTN. The Sims position is supine and side-leaning and not the right position. Myasthenia gravis, autoimmune disease, muscle weakness and ptosis. Weakness increases with activity, and ptosis is present at the end of the day. These are expected findings. Respiratory failure is possible, so monitor closely. Transverse myelitis, spinal cord inflammation, usually results from a recent viral infection. Classic symptoms include paralysis, urinary retention, and bowel incontinence. Some recover, others have permanent disability. Normal muscle strength, 5 on a 0-5 scale. Weakened muscle strength to plus means only able to move laterally, not able to lift up against gravity. This is expected. PF paroxysmal supraventricular tachycardia, HR 150 to 220 min, prolonged episodes can equals hypotension, palpitations, dyspnea, angina. Treatment: vagal maneuvers, Valsalva, coughing, carotid massage. Adenosine is the doc, administered rapidly via IVP over 1 to 2 seconds and followed by 20 ml saline bolus D or T. Its short half-life. An increased dose can be given twice if the previous admin is ineffective. Adenosine is an antiarrhythmic and a nucleoside. It works to treat irregular heartbeat by slowing the electrical conduction in the heart, slowing heart rate, or normalizing heart rhythm. It helps during a stress test of the heart by improving blood flow to the heart. Beta-blockers, CCEBs, and amiodarin can be considered as alternatives. If drug therapy is useless, synchronized cardioversion may be used. Defibrillation, used only in clients with VFil and pulseless VTach. External pacing and atropine anticholinergic used to increase HR, used in symptomatic bradycardia 60 minutes. Stroke, single most important modifiable risk factor, HTN. Other risks: diabetes, high cholesterol, smoking, obesity particularly abdominal, older age, and genetic susceptibility. Acute stroke treatment can give ladylnormidine or nicardipine cardini as antihypertensives. Permissive HTN is allowed within the first 24 to 48 hours of an acute ischemic stroke, provided the BP is to 20110 Hg. This allows the penumbra to be perfused to keep the stroke from extending. Myasthenia gravis, an autoimmune disease involving a decreased number of acetylcholine receptors at the neuromuscular junction, results in fluctuating weakness of skeletal muscles, most often shown as ptosis or diplopia. Bulbar signs: difficulty speaking or swallowing, and difficulty breathing. Muscles stronger in the morning and become weaker with the day's activities as the supply of acetylcholine is depleted. Skeletal muscles, not reflex or CNS muscles for bowel and bladder control, are involved in myasthenia gravis. Bladder issues are related to MIS. It affects eye and eyelid movements, speaking, swallowing, and breathing. Treatment: anticholinesterase drugs, mestinon, pyridostigmine, that are administered before meals so that the client's swallowing ability is strongest during the meal. Semi-solid foods that are easy to chew are preferred to avoid stressing muscles involved in chewing and swallowing, or liquids aspiration risk. Annual flu vaccine, also pneumonia vac, if appropriate, as they are more likely to have a negative outcome if the illness is contracted. Anticholinergic drug atropine is used to treat cholinergic crisis, too much acetylcholine. The need for this drug would not be needed during a myasthenic crisis, as it is a result of too little medication related to noncompliance, illness, or surgery. Pulmonary edema is a life-threatening condition. Clinical SS: history of orthopnea, dyspnea while lying down, or paroxysmal nocturnal dyspnea, anxiety, restlessness, tachypnea often 30 min, dyspnea, and use of accessory muscles, frothy, blood-tinged sputum, crackles on auscultation. Priority care: improve oxygenation by reducing pulmonary pressure and congestion. Diuretics, Lasix are prescribed to remove the excess fluid in pulmonary edema.